All right. Hello, everyone. Good morning, good afternoon, good evening from wherever you're joining us from. We are so glad you're here today for this special presentation. My name is Jessie Lane. I'm the Communications Manager for the CHAMPS Program Office, and I'm just getting us started off with a few housekeeping items before we get the webinar moving forward. First, this is our agenda for today. We are featuring some wonderful team folks from our social behavioral sciences team, and they're going to give an overview of what their team does and then also share case examples from their own experience in the field with CHAMPS. Following those presentations, we're going to have a Q&A session at the end, and we encourage you to submit questions through the Q&A box at the bottom of your screen. That's the easiest way for us to keep track of questions rather than chat. And any clarifications throughout the presentation we will address right away, but we may save more complicated questions for the end and for the discussion portion. So you all know, this is being recorded, and this recording will be available to you on our website, and we'll send it via email as well. And the slide deck is also going to be made available. Before we launch right in, I'll give a very short overview of CHAMPS. I think many of you who are here are very familiar with our work, but CHAMPS, or Child Health and Mortality Prevention Surveillance, is a global surveillance network that assesses and tracks causes of child mortality in the regions where it's highest. We have 7 active sites right now across countries in Africa and Southeast Asia, with imminent expansions to new sites in the works. When we had our webinar back in August, we talked about the CHAMPS data, and we hope that after this webinar, you will go to our website, look at the data for yourself. It's open access, and you can download the de-identified data as well as look at what the data summaries are on the website. We hope you share those with your colleagues, and we hope you use them in your own research as well. That webinar was very exciting, and it was also sort of the end process of what CHAMPS does. So now we're going to take you to the other side and show you how the formative work is done to establish a CHAMPS site and the work that goes on in the communities there. And that's where our Social Behavioral Sciences, or SBS team, comes in. So I'm going to hand it over to John Blevins, who is Head of Social Behavioral Sciences for CHAMPS, and Maria Maijenges, who is the Senior Scientist in Social Behavioral Sciences, and they will take us away. Thanks, John and Maria.
Thanks, Jessie. Maria will start by giving us an overview of the social behavioral sciences research methodologies employed during the formative phase and during our current phase after projects have been implemented. I'll turn it over to Maria.
Okay. Hello, everybody. My name is Maria Maijenges. I'm an anthropologist, and I'm part of the SBS CHAMPS program office, working from beautiful Barcelona in Spain. So I will introduce very briefly the methodology we have been using at the CHAMPS SBS. So first, to say that CHAMPS started in 2016, and there was a first phase where we needed to know the best way to introduce pregnancy surveillance, mortality surveillance, and how to perform it in a way that it was social, cultural, religious, acceptable, that was respectful and was in alignment with the community. So for that, we use phenomenology and formative research to create site-specific, very site-specific conceptual frameworks for feasibilities. And we focus on acceptability, practicality, and implementation, their variables and their relation. So data was collected from different methods. We use in-depth interviews, focus group discussions, observations, and from different key informants that were important to answer our research questions relating acceptability, practicability, and implementation, and then feasibility. And data was analyzed using grounded theory approach, thematic approach, and all the data, and we use triangulation to ensure trustworthiness. So in second phase, we start with qualitative rapid assessment. That is when we had already an idea of what was going on. So qualitative rapid assessment consists on studying a complex but a very specific phenomenon by collecting data in a very limited time. So normally in 6-8 weeks, we perform each qualitative rapid assessment, and we use interviews, focus group discussions, and observations. We use the framework analysis, and the objective is to inform on specifics of aspects for implementation. So in this webinar, my colleagues will present examples for qualitative rapid assessment. So now I give the floor to Professor John Blevins, who will introduce the community engagement.
Thank you, Maria. I want to talk briefly. I'm John Blevins. I am the Director of Social Behavioral Sciences for the CHAMPS Network, and I am an Associate Research Professor in the Hubert Department of Global Health at the Rollins School of Public Health at Emory, and work in the program office at Emory. I want to describe briefly a few components of our community engagement approach. The first being a series of interactive workshops that all of our sites, SBS teams at the sites, implemented in local communities with a broad cross-section of community members and with targeted key informant community leaders. PICCHAMP workshop stands for Participant Inquiry into Community Knowledge of Child Health and Mortality Prevention. The workshops were designed to help us to understand whether local community members and especially community leaders would find the activities essential for carrying out pregnancy and mortality surveillance, especially the minimally invasive tissue sampling, acceptable in the local community in regard to community beliefs and practices. And so PICCHAMP tied directly into the formative phase for giving us some understanding of context related to the topic domain and the variable that Marie mentioned of acceptability. But we also asked community members to tell us about community priorities that happen at the time of pregnancy and at the time of a child's death. The practices that happen within a family and a local household and among close neighbors when a woman discovers that she is pregnant, and the practices that happen in the community when a child dies, so that we could understand how those practices are important and take precedent and need to be respected as we carry out our surveillance activities. In this way, that tied into the topic domain and the variable of practicality. If someone hypothetically supports the idea of conducting our surveillance activities, in practicality, how can we support their decision to participate by minimizing disruption to those kinds of community priorities and activities that are really important to the community? So PICCHAMP provided a basis not only for us to enter into the community and describe our work, but also provided some contextual understanding to inform the formative research phase of our activities. Once we completed formative research and as we began to implement CHAMPS activities, mortality surveillance activities in our local sites, every site worked to develop a site-specific strategic plan for community engagement, focused on a set of core objectives that were contextualized to the site's needs and reflective of community structures in the sites. The first objective related to that strategic plan was to build partnerships with local organizations and leaders in the area of maternal and child health, and in partnership with those leaders and organizations to develop maternal and child health initiatives that were feasible to size for CHAMPS. CHAMPS is not a service delivery program, but we could develop small maternal and child health initiatives and health education initiatives that you'll hear about a bit in a few minutes that were appropriate to context. How could we develop appropriate communication mechanisms and understand the communication messages that were most important to local communities? And what would that look like to develop them? And how could we appropriately demonstrate respect and appreciation for families who consented to participate, and to our communities and our catchment area that allowed us to conduct our activities? And those activities needed to be contextualized to community norms and community practices, particularly in relation to practices and norms about how death was commemorated and meaning made around the death of a child. Once MITS commenced, and at this phase for our community engagement strategic plan, we have 3 additional objectives that are in place. One is to track and to be able to respond quickly to rumors as they break out, and to develop a multi-sector and multi-pronged approach to rumor response and surveillance. Mechanisms for providing feedback on the causes of death in children within our catchment area to the local communities at aggregate level data, so that our community members as a whole understand the causes of death in children in their communities. And then mechanisms and structures for community leaders and key stakeholders in our catchment areas to have input on data to action initiatives and activities. That involves both including leadership within the sites from the community engagement and SBS teams on data to action planning, as well as gathering input from key stakeholders in the community on data to action implementation and programming. We're going to turn now to hear from case examples from a few of our sites on qualitative rapid assessments. We'll hear from Bangladesh, Ethiopia, Mozambique, and Sierra Leone. I'll turn it over to my colleague, Shahana Parveen in Bangladesh.
Thank you, John. Hello, everybody. I'm Shahana Parveen, leading the Social and Behavioral Science of CHAMPS Bangladesh site. Today, I'm going to share you one of our unique rapid assessment experience. Since the inception of MITS implementation in our September 2017, our team has been introduced an innovative approach of interviewing family decision makers of approach cases to understand the decision-making process and contributing factors that associated to MITS consent. We conduct the assessment in different time intervals and at need basis, specifically whenever there is a downtrend in our site, so that we could identify the actionable point for further improvement. So this is a continuous assessment process. During each time assessment, the team reviewed all approach cases in a certain time frame and select some cases for further interview. We basically explored on 7 points in this assessment process. First, we asked participants what they could recall about the content of the consent, so that we could identify any potential misconception or misinformation and to ensure ethical quality. We then explored the detailed decision-making process, including person involved, level of interaction and decision made, and who took the final decision. We explored what was the reason or contributing factors that triggered them to a certain decision. We list down the concerns reported by the participants or which came out throughout the discussion. We also asked if they shared their MITS experience, that means MITS approach experience with other family members or neighbor, to understand their attitude or if they have any concern for sharing with others. We explore participants' intent for future participation, or if they would like to suggest others to participate in MITS if they would experience such an event. Finally, we explore whether participants had any pre-exposure to CHAMPS activity or MITS in the community, and also when they were in the hospital. Next slide. Based on our assessment, the team then identified and developed actionable recommendations to be implemented by the multiple team in our site. For example, during our last assessment, we tried to identify the reason why more cases were unable to approach and refuse for MITS consent, and based on the findings, we recommended to strengthen the communication with family by MITS team during ward round with live patients. We suggested the team to ensure they are following morning periods before an approach. We emphasize that during consent approach, consent taker shall ensure family understood needs, method, duration, and result sharing time to avoid any kind of misconception or misinformation. We also recommended to reinforce community engagement activities through refresher, village meetings, follow-up with the family over phone after an approach. Since we had this opportunity to talk with the family member in the community, apart from this consent approach, additionally, we also explored participants' suggestion to share meet segregated result with the broader community. We asked for their opinion about extending time frame to visit a household and approach for meets when there is a death in the community. And we also asked their opinion about the feasibility of meets facility in mobile lab. So that's all for from my side. Thank you.
Next is Berhanu Damis from Ethiopia.
Thank you. Thank you all. I'm Berhanu from Ethiopian CHAMPS site. I am sociology background and working as a social science national team lead. So I will present our experience and how our site is working on the qualitative rapid assessment regarding the rumor surveillance activities. So when we start the feasibility study of CHAMPS, community hypothetically accepted the implementation of minimal invasive tissue sampling in our site. And after meets commenced in the middle, there was the spread of rumor in the community, which considered CHAMPS as kidnapping, like we are in the community to chase children, especially kidnapping and us involved in harvesting organs of main organs of the under 5 children. And there was like a rumor, like we were called as blood suckers. So this was actually a problem happened in our site. So these were actually unverified and like an explanation that actually happened in the community, circulated in community setting, though it was not grounded to the objectives of the CHAMPS activities. Then our sites developed how we can identify and just tackle this problem so as we can really address the problem. Then we identified the source of the rumors. We conducted qualitative rapid assessment to know the source of the rumors and to work over it. Then we have analyzed the findings and developed a report that helps the site to develop an action plan and recommendation so that we can work on activities and create awareness among the communities. So as a recommendation, the site working on the actionable recommendation developed because of the rumor surveillance rapid assessment. We've tried to address the community attitude, expectation, concerns regarding the rumor mentioned. Then we developed a robust community engagement approach to communicate CHAMPS objectives using different approaches, like using the local radio program to promote the objectives of CHAMPS activities. We have used the local theater for development approaches. Then the community members come together and then we have a local actors who contribute, like playing the activities of CHAMPS, acts as community members. Then we really address our objectives in that play. We have also used health education program, health outreach campaign, community conversation events, then other approaches to reduce the mistakes and overcome the misunderstanding in the community. Thank you.
Thanks, Berhanu. We'll now hear from Amilcar in Mozambique.
Yes, thank you, John. So this is Amilcar from Mozambique. We are talking about the rapid assessment, the community perception, so our CHAMPS approach to community activity in the COVID era. Since the beginning of the pandemic outbreak, CHAMPS in Mozambique, CHAMPS adopt new community approach related to some activity regarding to notification of death, request consent to perform meets and deliver results. to contain the spread of COVID during those activities. So we have little or no information about community perception of those new approach that CHAMPS are implementing during this community activity. So on this RAPT assessment, we assess community experience and perception of CHAMPS community approach in the time of COVID pandemic. The two research questions of this RAPT assessment was how community member perceive CHAMPS community approach at the COVID pandemic era, and how appropriate our CHAMPS community approach at the time of the COVID pandemic in the community life. So from this RAPT assessment, we made some analysis, and there is some data recommendation. John, can you move to the next slide, please? Okay, some actionable recommendation for this RAPT assessment is the strengthen information about community in ways to minimize the risk of CHAMPS infection in the community. Project key knowledge recommendation and clear communication about COVID prevention at the community. And during the CHAMPS community activity, reinforce the knowledge of prevention behavior regarding to the community member. Thank you.
Thanks, Amilcar. Now we'll hear from Abdoulaye Ba in Sierra Leone.
Good afternoon, good morning, wherever you are. I'm Abdoulaye Uthman Ba. I joined the CHAMPS team in 2017 as the formative research lead. Upon the departure of my SBS lead in March, I was given the task to manage the team, to not only now do the formative research management, but also to incorporate the community engagement. So that is how I came in. So I start with the background. When we started decoding the cases, we decoded onto 40 cases, but there was signal coming from the decode in terms of information sharing, which revealed some negative opinion on clerical staff with the perception that they are negligent to the causes of death. So these data were communicated to the staff by some of these decode panelists who were also members of the MOAHS. So there was some rift between them and the junior staff they have at the hospital about the outbreak of a Klebsiella pneumoniae, which the ministry saw as something that was like, it's only CHAMPS that is coming to detect an outbreak like this. They are a little bit not surveillancing their own system well. So because of that, there was this blame game that was going on back and forth. So what we did as the SBS, we initiated a formative research that was dubbed as the healthcare workers' concerns about the decode result. And based on the findings, we had to find out that the communication system was not managed well between the senior hospital administration, who are also part of the decode panel, to the lower staff or the clinical staff. So they threatened that they will have to withdraw their collaboration they had with us. So what we did was for us to be able to interview them using a formative research methodology, for us to find out their concern, their genuine concern. It was after we find out those concerns, we are able to modify the process so that we talk to the community, the set of healthcare workers, for us to be able to talk to them that this is not a point of blame game, but rather they should take up the responsibility to see that the activities they do in the health facilities are contributing to deaths, and that is a very big concern. So the recommendations we had was to reinforce clinicians' essential role in the improvement of maternal child health, and we modified some communication and approaches as to how we deal with these healthcare workers. So we empower clinicians and staff to adopt new SOPs regarding to how Klebsiella could be prevented. So being that Sierra Leone site is a little bit unique, the work streams are being implemented by different implementing partners. All of these findings were communicated to these various units, and they were able to take action. Like the MITS team, which is run by ICAP, they were able to do some cleaning at the SCBU, which was source of the Klebsiella. So they used some of the cleaning system, they fumigated the entire SCBU, and not long after that fumigation and cleaning exercise, there was a very drastic reduction of deaths reported from the SCBU. So that was one of the key things that came out of that research that we did. It was able to inform both the mortality surveillance and that of the other MITS team for them to be able to really isolate that type of bacteria that was leading to cause of death of children. So by and large, that was what we did. Next slide. Next slide. So let me start with the community engagement case. In partnership with the Ministry of Health, we are able to disseminate health education information and materials and resources to address the cause of death in communities within the catchment area. How did we do that? You know, when we started, for us to be able to be successful in Sierra Leone here, we didn't reinvent any wheel. What we met as Ministry of Health, as health messages that are approved by the MOHS, were the health messages we called for them to be able to share with us so that we'll get back to communities. So when we had decode result that was pointing out to high level of malnutrition, malaria, poor hygiene, and health-seeking behavior, we adopted these messages and changed our messaging system to reach out to these communities. So much of the topic we included were just on malnutrition, because the data pointing to us that close to 40% of all causes of death from this site is pointing towards malnutrition, and 15% is pointing towards health-seeking behavior. So I think there's a very big chunk of data, so we could go back to communities to tell them that these are the leading cause of death, so that they can also initiate some action that they can do for them to be able to reduce child illnesses and deaths, and that is yielding some fruit. We disseminated through the media campaign using the radio and the IEC with all the other networks that we have, the Comora network, like the religious leaders, the press, the traditional healers. We all have all of this network. We use them during the radio discussion program. We invited the mortality surveillance team to talk on key issues relating to child death during the radio discussion program. We have posters. We've developed hundreds of those posters. We were able to distribute all of them in 106 local villages we have in our catchment area, including the 7 wards in McKinney City. This kind of activity allows the team to address misconceptions and increase acceptability of the project and mortality surveillance activities. Now, rumors are coming up and misconceptions and what CHAMPS can do and what CHAMPS cannot do. So we are able to develop messages for us to reach out to the community to say, CHAMPS is not a provider of all the services, because most of the things that they always show us as a concern from here is about this free healthcare, and most of these free healthcare facilities are almost always not available, or if they are available, they are restricted, they are not able to get to the right users. So most of these things that whenever they see us as CHAMPS, they will begin to complain. You people should bring us drugs. You should bring us, you should provide clean water for us. But we always tell them that this is just a way we could find out what is leading to cause of death. And if we have this information, we'll be able to escalate it to whosoever could provide these services, and we'll be able to influence policy and other decisions government can make, including allocation of resources, because these communities are highly deprived. So each time they see you, they see as if you are the messenger going back to the Ministry of Health because of our link with the Ministry of Health being the leading partner in the CHAMPS site here. So that is why we are always serving as a link between the community and the MOHS again. What we can provide, we will tell them. What we cannot, we will also tell them. And we are able to minimize that, because at the start of the program, the expectations were so high from the community to say we'll come to solve all of their problems. But we told them that no, we want to just find out what is leading to child illnesses and death. And when we have those information, we'll come to you back again. You will also be a contributing person to drive down the mortality at this site. Thank you.
Thank you, Ba. As you've noticed now, we've moved into case examples of community engagement activities, and Ba gave the first for Sierra Leone. We'll move back now to Mozambique to provide a case example on community engagement.
Okay, thank you, John. So related to community engagement in Mozambique, Mozambique team community engagement employ several strategies to improve health outcomes through the community engagement. So, for example, we use the code data, the code panel findings to inform health information and education campaign through the health fair, community radio, and community literature to teach community member feasibility initiative to improve health outcome of maternal and child. Another strategy that we are implementing is the contribution of childhood illness and death in inadequate transportation service that are limiting INC outtrack or INC visit and affect the maternal and child health, and often keep family from seeking clinical care during emergency situation. Under the leadership to community engagement team from CHAMPS, we are implementing and we will develop a sustainable transport strategy with the community member that work to help the community to facilitate there to take care and on time to take the community member that in illness situation and in emergency situation to the health facility or to the clinical to treatment or an emergency height. Thank you.
Thank you, Amilcar. Our colleague from Mali, I don't think is joined. Kunanji, are you on the call? Let me briefly just summarize Mali's approach to community feedback. Working with community leaders and key stakeholders, the team in Mali worked to assess the best way to conduct community feedback events in the catchment areas to let members of the community know about the findings from DECODE and to tell community members about the most common causes of death in children in the community. Based on a series of activities, it was determined that these events should happen at least twice a year, that they be carried out within the community itself, and that such events specifically engage and target key stakeholders and key members of the community that were essential for the success of CHAMPS, including community relays, who are community health workers, morgue attendants who participate in the death notification process for CHAMPS, other community and religious leaders, women leaders in particular, and members of professional and psychosocial service organizations. There were efforts to not only understand how these activities, community feedback activities, should be carried out, but how other activities and meetings in community engagement could be best implemented to improve acceptability and trust for CHAMPS and its activities. There was determination that CHAMPS should present these results not only in the community, but in a number of other locations, including health facilities, next slide, and with the Ministry of Health and Public Hygiene. That in regard to these efforts to engage clinical facilities and Ministry of Health leaders, that the findings from the community would support ongoing health reform and could have an impact on the sectoral health and population policy that has been in place within Mali for a number of years. That requires a multi-sectoral approach and response, which is reflected in the way the Mali team conducts community feedback sessions. And a key message in the sessions is not only to present information on the causes of death, but to reinforce the idea that everyone has the power and agency, as well as the responsibility, to contribute to reducing the death of children. Thank you. We'll go on to the next group, to Bangladesh. Farouk, I'll turn it over to you.
Thank you, John. Hi, I work as the Community Engagement Lead in CHAMPS Bangladesh implementation site. So we already know that CHAMPS is a very sensitive program that aims to identify cause of deaths of stillbirths and children under 5 years of age through minimally invasive tissue sampling procedure. So MITS procedure has social, religious, and emotional perspectives and implications. Ultimately, community trust towards the CHAMPS implementation is essential. Community champions are some of the selected persons with specific knowledge and experience who could support a program at community level. So we aimed to develop social connections between some specific persons who closely know about MITS procedure and the families of the children who died in our surveillance hospitals. With these selected persons, we wanted to develop a pool of contact so that they can explain their personal experiences with CHAMPS team to the deceased families that our team attempt to approach for MITS consent. We selected community champions who had closely interacted with our teams at hospital and in the community, observed consent approach process, supported deceased families to decide on MITS procedure, and some of them also joined when we delivered MITS report or the decode findings to the participating families. There were not many people we found had these interactions and roles performed, but we found 7. So the initiative or the community champion approach, we found it worked. Although the success was limited, only 4 families consented out of 15 families to talk to any of these champions. So we learned that the community champion approach helped increasing MITS consent, but the limited number has restricted the opportunity to consult with them or talk to them. Therefore, for a large community, we are targeting to recruit more community champions so that the deceased family members are familiar with them and they show interest to talk to them during MITS consent approach. So that's all from Bangladesh Community Engagement site. If any questions, please drop in the question and answer box. Thank you.
Thank you, Farouk. We're going to now have a discussion, time for open discussion. And we're going to start with a few questions that we wanted to make sure those of you on the call were aware of and that are quite common in regard to our work as a team across the network. So the first question that I'm interested in hearing from our SBS team panelists from the sites is your sense of the ways that social behavioral sciences contributes to CHAMPS and its overall efforts in your country site, and what does community engagement contribute to CHAMPS? Anyone have thoughts on that question?
I would like to start. This is Shahana. we considered that in our site we contributed in several areas. I would like to just quickly highlight some of the areas. We support to identify any kind of misconception or misinformation during our consent approach through a continuous monitoring system that really ensure our high ethical aspect. We recommend several strategies such as developing a good rapport, how to communicate with the potential case patient in the hospital, which actually could pave for an enabling environment for MITS approach. We also develop strategy for community needs for approaching in the community level for when there is a death in the community. Our team also supported to develop the strategy to share the decode result with the family and how to communicate the preventative measure with the family. And finally, we also develop communication message based on the major cause of death from the decode result. And our CE team actually developed a strategy, a communication strategy, and implementing in the field. And finally, I'd like to remark that SPS team is continuously providing recommendation to other teams, such as community engagement team and the remote team, how to minimize any rumor or any kind of related issues. Thank you.
Thank you, Shahana. It's always astounding to hear the degree of work that SBS teams are doing in our monthly calls with the teams. Do others from other sites have additional activities or additional messages you'd like to share in regard to SBS contributions beyond what Shahana has offered?
Yes, let me continue from where she stopped. At the formative stage, the SPS Sierra Leone here, we are pivotal in making all the necessary collaboration with community leaders, rulers, the MOHS structures like the DHMT here. We are able to have a collaboration with them. They were part of the formative stage. They attended and facilitated almost all of the workshop, big CHAMPS workshops, and they have been contributing immensely in facilitating most of the workshops because they have a pool of knowledge where we tap into for them to be able to reach out to communities. We have been able to do that. We, at the site here, serve as the foot soldiers. We are always at the community level. We take the concerns of community people back to CHAMPS and we deliberate with the site management here, whatever solution to problems they have from communities that will limit their acceptability, we are always there to solve them. So this has been the contribution. We are always ready. We have a standby team that can really get into communities whenever there is an emerging issue. We have been able to resolve series of issues that are of misconceptions. When there are refusals, we investigate these refusals. We make sure we inform the other work streams about the causes of these refusals, and they have been working on those areas that we think we are lagging behind. And because of that, we have seen an increase in acceptability at the site here. You can recall that when we started here, we were just 1 year after the Ebola. So there was very heavy tension that they will link that Ebola with the minimally invasive tissue sampling that we are about to introduce. We were a little bit jittery and we were afraid. But because of the structures we have, our relationship with MOHS, who are trusted at the community level, our relationship with the chiefs, we gave them some information that was very relevant for them to be able to really differentiate between the Ebola and the minimally invasive tissue sampling. So that tension that we anticipated, we are able to resolve all of the issues that we are coming from those tensions. So fortunately for us, we are also anticipating we will have a religious backlash because in the site where we have close to 80% of the inhabitants of the site to be Muslim. And we have very Orthodox Muslims here. We are anticipating that there will be a backlash. But what we did was for us to train imams and the pastors. They came in clearly with messages that accept minimally invasive tissue sampling. And they served as the initial champions They were spreading this information for us in almost all of their congregations. So because of that, their role, we are able to neutralize the tension that we anticipated. So the religious leaders played a pivotal role. We did not only deal with religious leaders, we also dealt with traditional healers, who are almost at the first point of call for all medical uptake in the site here. But we have been able to turn that tide down and make sure that we have a memorandum with traditional healers that they do not treat under 5 children. Let them always serve as referral point for us, for them to go to the clinic. And because of those messages that we have sent to communities, you don't see traditional healers treating, unless otherwise, because we cannot say 100%. But we have an agreement with the head of traditional healer here that anybody that treats an under 5 child and that child dies, they have a way they can reprimand that person within their own internal system. We did not say they should sanction them that way because we don't have that power. But because of the good cordiality we have with them, we have been calling them in meetings and orienting them about what CHAMPS is doing, and it will help reduce child mortality. They were able to accept that one, and they have not been practicing that. Also, what we did was we have a high rate of drug peddlers, those people who sell this drug over the counter. For us here, they use motorbikes to sell drugs across the 106 local communities. But because of the knowledge we've given to the health, to the CHWs and those we call the community reporters, they are very, very vibrant to see that if there are any people going out to sell drugs, they tell their community people, don't buy this drug, go to the health facility. And fortunately, most of our health facilities are within 6 to 7 kilometer radius. So you can be able to get there. So these are the activities we have been doing. And whenever there is a new activity, as an SDS, we are the first people to go and introduce it to the communities. The year coming in, we'll be introducing pregnancy surveillance out of DSS. So we'll be very pivotal in getting to the communities for them to understand firsthand before even the initial implementation of the program. So by and large, we have been very useful in making sure that we convey all the messages from CHAMPS, and whatever information we see from the community people, we'll bring it back to the CHAMPS team's lead for them to decide on it. It has worked very nicely over the years. Thank you.
Thank you, Ba. You've raised a number of issues about the complexity of conducting community engagement and social behavioral science research in the context of CHAMPS, such as issues of engaging key community stakeholders and religious leaders. It brings up the second question, which is a common perception we hear from our SBS teams that in the community, because CHAMPS approaches family members at the time of the death of their child, that our program is often perceived as a death program, even though we focus on improving health outcomes for mothers and children. I'm interested in hearing from Amilcar and Farouk and who am I missing? Amilcar, Farouk, any of the other SBS team members who are here about how your work offers another perspective for challenging the idea that CHAMPS is a death program. Berhanu, sorry, Berhanu.
Yeah. Thank you. This is very interesting question, John. So in our site, that was really close to impossible to start and implement minimal invasive tissue sampling. And there was a frequently asked question, like community members ask, like, why CHAMPS wants to know the cause of death after days, because mortality surveillance in our site was found like very unique and something uncommon in the site. So we frequently heard the question and the concern of community, why you want to know when the cause of death, when children are dying from like malnutrition problem, like they can know it, or something like vaccine preventable disease mentioned in the discussion. So we've had this problem, and that there was actually a difficult time to communicate CHAMPS. So social science contributed a lot in communicating CHAMPS and the objective of CHAMPS. So we try to create awareness for the community regarding the activities of CHAMPS, and we also focus on the alive children. We developed other community health initiatives, like working, developing our weekly clinic with the local health centers. We try to promote health activities. We have a health outreach campaign in the community setting, so that we really demonstrate activity that focuses on the health of mother and child. Then we try to show the community we really care for the health of children. We not only work on the days. So we also try to communicate how the finding from CHAMPS or the cause of days contribute to ensure the health of children after that, starting from the result communication and maybe informing the policy formulation activities. So there was a time we labeled as a dead project, and people looking for only the dead bodies, not doing anything for the children alive. And the contribution of social science was amazing, and we tried to overcome these challenges. And we are trying to do things, especially after the data to action started. I think there are visible activities we offered another perspective than considering CHAMPS as a dead project. Thank you.
Thanks, Berhanu. I want to briefly note that our colleague from Mali, Kunanji Diarra, has joined as a panelist. Kunanji, we're glad you've joined us, and I wonder if there are any comments you'd like to make before I turn it back over to Jesse. Kunanji. Kunanji, do you hear? Can you hear us?
C'est juste pour dire que toute l'équipe est là, tous les membres de l'équipe SBS sont là, et que nous suivons avec intérêt ce qui est en train d'être dit par les panélistes. Voilà, merci.
Donc, tous les processus qu'on a engagés et notre contribution à CHAMPS, on ne pourra pas revenir dans les détails, mais c'est à peu près ce que les autres ont dit. Depuis le départ, so all, I think we have, the SPS team has contributed a lot to the CHAMPS process, even from big CHAMPS to the community meetings, to the implementation to address the practicability issue, acceptability and feasibility. And it is for this reason, even sharing the result of a decode result was an opportunity to give more information, and we have also community meetings in the two areas with the communities to address the problem. They may ask have a question, and also to come with the main issues we are dealing with, and also to find together solutions to issues raised. So we are contributing to the verbal autopsy and also to other activities. So we are supporting the CHAMPS activities here, and all the team is listening to this webinar.
Ce que je voudrais ajouter, c'est que réellement, pour l'engagement communautaire, pour renforcer l'engagement communautaire, il faut réellement être en phase avec la communauté. Renforcer, être régulier au sein de la communauté, comprendre la communauté et exercer ses activités dans les normes éthiques par rapport aux activités de la communauté. Comprendre la communauté, connaître les normes sociétales et mettre en exact les activités du CHAMPS conformément, c'est-à-dire tout pour l'adapter aux réalités socio-culturelles de la communauté. Voilà.
Kunangi is adding that to get community engaged, we have to have a permanent link with them, to discuss with them, to assess what are the problems, and to find a solution to this problem. So we have to be in regular contact with the communities, and this is done through the community engagement activities. This is what we are.
Thank you to Kunanji and Professor Chiman as well, and to the team there in Mali. We appreciate you joining us and all of the work you do to make CHAMPS Mali a success. I'm going to turn the session back over to Jessie and let her take it from here.
Thank you, John, and thank you to all of our panelists. I know we have some questions here in the Q&A, but we are almost at the hour. So if anyone needs to drop off, we certainly understand, and we will keep recording if any of the panelists can stay and address some of these questions. We'll have that posted online and emailed to you later. So John,
I'll also write a written response out to the questions that are in the Q&A that you can post up as well.
Oh, lovely. Great. Would you like me to just go ahead and look at some of these questions here and John, you can direct them?
Sure.
All right. So we have one that was about the quality rapid assessments in Mozambique, I believe. Curious to know about community people perceiving community myths approach during COVID-19 pandemic, visiting the household, discussing with family members in close contact.
So I'll turn that to Amilcar. Amilcar, how do the community perceive CHAMPS activities related to conducting myths on deaths that occur in the community in the context of COVID? And what did you have to do to modify in response to those perceptions and in response to safety?
Thank you, John. So from the beginning, we start some community activity to arrange and think new approach to go to the field or to abort the community. And one of the first strategies was to start with the meeting, short meeting with the community member and community leader, explaining them that CHAMPS will change some approach to abort community member that will not be comfortable, maybe because we now have some limitation. There is people will appear with face mask, and CHAMPS team member will ask community member and community leader to disinfect their hands, and there is biosecurity protocol that we are using to prevent CHAMPS team and to prevent the community members too. So this is why we call that the change of the approach, that we did like to understand if the community member or what the community member said about this minor change of the approach to abort and to speak with the community member. So on the beginning was weird to work with this new approach. Even some consenter, they said it's difficult because when they abort a family, mother or the parents of a child death, to ask them to meet consent, it's not more, it's not open, because the distance obligatory to each other, and using face masks, asking to disinfect their and make some kind of make distance between the consent and the parents, for example. But with the interaction and explanation that we are doing this because of the COVID pandemic, and ask the community member to accept and to understand, this new approach was a good strategy. And now I think we are on good way on this several approach that we implemented in and consent inform and DSS, community activity, community meeting, community literature, etc.
Thank you, Amilcar.
Thank you. John, how about we pick maybe one or two more and then the rest you can answer in your written response?
Sure. Would you
Okay.
like, you want me to, no, go ahead.
I can take a look and choose one. Let's see. Here's a question that says, what kinds of messages are best understood by the community, and how are these messages broadcast on the radio in the form of spots or information programs?
So I'll open this up to different team members from the SBS teams and the sites, because many of our sites use radio and other media to provide information to the community on health information as well as on CHAMPS itself. So does anyone have any experiences on the most effective kinds of messages and communications from the point of view of the community?
Hello?
Hi.
Hello. Well, we are working with communities in direct contact. So we can say something about what comes from our community meeting, and every issue related to the concern is taken into account seriously, and they even contribute to this. But here we have a plan to use media and to use also actors or small theater, but this is we have not yet experienced it. It is ongoing. So the type of message through the media, we have not yet experienced it in Mali.
Thank you, Chiman. Would others like to add?
Yes. From the Sierra Leone site here, we are able to engage the media first so that we give them the necessary orientation before they could get to the people. And it has proven to be very, very effective, because each time there is a radio broadcast, it's a simulcast broadcast. It's run across all the 5 radio stations. And we did a research to find out the peak time that people listen to radio programs and the most listen to program. So it is within the program time that we normally use between Saturday and Sunday for us to get to the communities. Radio programs have been very useful for us, because when we have the rainy season, which span like 3 to 4 months, there are some communities where we don't go to. So the best way for us to convey a message to them is through the radio. So they have been very, very useful in getting to communities that we can not go to in 3 or 4 months time, because of it is too risky for the staff to go through those roads and convey because of safety reasons. So we have been using the radio, and the radio is well trusted. We don't have print media here because of the level of literacy, but because radio, when it is being done in the local languages, they are always ready to listen to it. And it's a live phone-in program. It is through those sessions that people call and ask questions. And when once you ask those questions, it will be able to reduce the level of rumors and concern in the community. So that is what we have been doing.
Thank you, Ba.
Thank you. Do we have time for one more? There's one question that says, could we elaborate about the transportation network?
Sure. Amilcar and the team, his colleague Sakina, have developed a really interesting resource in the community with the transportation network. Amilcar, could you describe that a bit further?
Yes. So the main object of this strategy is to help a community member with their in their emergency cases. For example, we realized that some of the community member during the community engagement meeting, community member are they are talking about that they have difficult to take the people in crisis or in illness case to the health facility on time, even to take some pregnant women on time to the health facility to give a birth. So that's why community engagement team think that is the possibility to engage the community based on their community, on their transporter, to create a strategy based at the community level to help the community to save his life. For example, if one community member are in need of transport to go to the health facility, they just take they notify the transporter, and the transporter take the person to the hospital. So during the days or the weeks or month, the community member give some money to participate or to contribute to the community transport. This contribution is used to the gas of the car and to pay some money to the transportation and other related necessity during this transportation process.
Thank you, Amilcar.
Great. Thank you all so much. I think we'll wrap up here. A big thank you to all of our panelists. We so appreciate you joining us and telling us about your experiences in these unique case examples. Thank you to everyone who joined to watch today and who submitted questions. All of those questions will be answered, as John said, and all of this information will be posted on our website and sent via email. Keep your eyes open for future webinars and sessions like this, where we'll keep talking about CHAMPS's work and share more. Anything final from you, John or Maria or anyone else?
Maria, anything you'd like to add?
No, just thank you very much for this opportunity to show our work, and of course, anything you need, we'll be here.
And I just want to say thank you to the SBS leads who were on this call, and to the other leads at the sites that were not able to make the call today. Your work is essential to the ongoing success of CHAMPS, and is pivotal to creating trust in the community and building partnerships. So thank you for what you're doing to make CHAMPS a success.
Agreed. Thank you, everyone. If you have additional questions, you can email them to info@champshealth.org. Otherwise, we hope you enjoy the rest of your day. Thank you so much.
Thank you.
Bye.
Thank you so much.
Bye.
Bye.
Bye.